Well, thank you very much for joining today. This, what I believe is likely to be the final meeting, at least at this stage. And we'll want to wrap up today. We address a question that I've received about making the actual submission public. I have not consulted with Dr. Weaver about that. She is out this week. And I will do that on Monday. And we will find out whether or not she has any reason why it should not be made public. There may be a good one, and I don't want to preempt that by sending it out now. So we'll find out. And if it is what I anticipate it to be, perfectly fine to do, then we'll put it on the web, we'll put it on website. With that, I'm going to turn it over to the recently returned from the Panama Canal. Tara, if you'd like to take over for a little bit and drive and move it along.
Thank you. First of all, thank you to everyone from the Department of Health and FSSA and consultants and advisors, people who provided their input, opinions,
Orange
ideas.
juice on the way home.
There was a lot of information that was shared with us during the process. It was very quick. So we appreciate everyone who activated very quickly. Sometimes people put their day jobs aside to make sure that we could get this completed on time. So we appreciate the collaboration that occurred. So today we're going to go through the timeline, governance structure, the application initiatives that were submitted and the key priorities, the regional grants timeline. I know that's one that's of most concern. It's a significant portion of our application. And then hopefully we'll have some time for questions and discussion, but hopefully we'll be pretty thorough in the presentation of what we wanted to share today. So as this is the same timeline we've been looking at for the past few weeks. And so we're now beyond the point of the application submission. We were very happy to submit it on November the 4th, and it was accepted. We received an acceptance. We did learn that all 50 states did apply. So we will wait to hear. We hope that we will start some engaging conversations as soon as they reach out. We did learn that for every state, there would be 2 reviewers. So it was, there was no, we were told multiple times that there was no AI involved in the application reviews, which is what we had been hearing at the beginning. There were real people behind the reviews, again, keeping in mind what the objectives are for this program. So we're optimistic and looking forward to hearing more. So here we are, November 13th. December 31st is the date by which we should have received information about an award, and then funding is expected to be released at that time. So that's all we know. That timeline has not changed.
Just how they're gonna spend their money and their billions of dollars.
Hey Tara, we can't hear. The audio was muted.
You hear us now?
So
Any better?
Good.
Yes.
Online? You can hear us? Okay. So please don't hit mute all if you're online. Just mute yourself if you are inadvertently off mute, because when you mute all, it shuts us out as well. Okay, so I think it's important to look at this map because I think there have been concerns about when we talk about statewide initiatives that, you know, we're focused on outside of the rural population, and actually we are not. You know, when we look at statewide initiatives, we're looking at all the blue areas here. So I think it's important to keep that in mind, that the rural health and the rural communities are the focus here. That doesn't mean that some large hospitals might not be impacted because of who they serve and how they serve them. So we want to keep that in mind as we're going forward. Again, this is a collaborative effort between Indiana Family and Social Services Administration and the Indiana Department of Health to engage stakeholders statewide across the board. So application development, again, this isn't a new slide. We'll get into a little bit more about what our steering committee and the process looks like, especially when we get into the regional grants. So this was a slide that we shared last time. So with the first initiative, you can see at the top of the slide, we have 12 initiatives. This is the first one. So I'm going to turn it over to Dr. Eric Yazel, who's going to walk us through this particular initiative.
Hey, good afternoon, everybody. Sorry I couldn't be there in person. I think you guys have heard us talk a lot about the Regional Medical Operations Center model. Basically, it's facilitated interfacility transfers from our critical access hospitals to definitive care with connections to local EMS resources to improve timeliness for our time-dependent medical conditions, strokes, traumas, things like that. Phase one will be getting our operations down and smoothed out. In phase two, we'll move on to what we call bidirectional flow, which means we'll be able to connect patients in our rural areas to regional services as available. So maternal health, pediatrics, behavioral health, things like that. The other benefit of this is scalability in the means of a mass casualty or large scale event or something along those lines as well. So as you can see, a budget $56 million over 5 years. That allows for staffing, the IT involved and things like that. Some of our outcome measures, bidirectional transfer coordination. So on the other one thing I didn't mention is also facilitated discharges from our tertiary care centers. So when you have a patient who's going back to a rural area with complex medical needs, the Regional Medical Operations Center can begin coordinating that transfer, you know, essentially upon admission at the initial facility, so that when patients go back to rural areas, they have the means to get the care they need and hopefully allow them to receive care in their local areas and prevent unnecessary readmissions. Again, we'll be monitoring the speed of transfer for our time-dependent conditions. Also, we'll have some opportunity in real time to give our EMS services feedback on capability of facilities and crowding information so they can make better destination decisions. And then also this data will all allow us to examine our hospital capacity as a state in general and make important clinical decisions based on that capacity. So that's kind of the quick mile high view, but certainly available for any questions now or offline if need be.
Just to be clear here, these were my new glasses too. I believe that says $56.2 million. That's over what period of time?
5 years.
Thank you. And is this front end loaded? Is the spending on this initiative front end loaded?
It is. It's mainly upfront would be just the IT costs, and then the yearly thing, a lot of times it's more just the staffing costs for the operators that would be directing these patient flow issues.
Okay.
So I think 2 points here. The budget that's listed on each initiative at the end, we have a listing of each initiative and the amount and then the percentage of the overall. So I think that's helpful to see as we're going through these because the numbers are vary quite dramatically across each of the initiatives. But the number value that you see for the budget is for the entire 5 years. Some of them involve a planning period. Some of them involve implementation sooner rather than later. So it all depends. When we submitted the application, we had to have everything broken out by year and the estimated spend for each year as well. Growing community connections through Indiana 211. So again, we talked about this last time. None of these are new initiatives that have been added. They were just vetted a little bit more thoroughly, and integrating referrals and social determinants of health resources, related resources to individuals, and making those easier to access across the board. $3.3 million is the estimate. This is more of an upfront in year 1 or year 2. Some of these initiatives were just an initial investment of the infrastructure, and then the ongoing, continues even before the 5 years. And so the initiative doesn't necessarily have to last the entire 5 years. For some of these, the establishment can occur, and then we can have it operational before the end of the 5 years. And again, we talked, are there any questions about this, or for the sake of time? I think we have a lot of slides. I didn't want to spend too much time. I think there's some that might lead to some more discussion, especially when we get to the regional. So I'm going to turn it over. Oh, sorry, I'll go through this one. The growing improved patient outcomes through enhanced interoperability and technology. This is a significant, improvement here for modernizing our health information exchanges to connect 450 rural healthcare facilities, and close some data gaps and strengthen care coordination through EMR integration, AI-driven dashboards, and EMS collaboration. So this is a very technical solution here. Again, this one is at the statewide level. There will be inside the regional grant opportunities, for individual hospitals and, depending on what that particular region needs. But this is to ensure that statewide, we have the communication needed to make this effective as people are moving across different healthcare.
And Tara, what's the total we could spend on interoperability of this kind of technology? Is there a cap on what we could spend?
10% of the total.
10% or 15%?
I'd have to check.
All right.
I think it's one of those.
And then there's a cap also on, new EMRs. There's a cap on
Okay,
certain
so-
parts of
so-
that as well.
So we have those restrictions
Oh, yes.
someplace that
Yes.
the public can see?
Mhm.
Okay.
We do.
So as the communities put together their pieces, they should be aware that that's an overarching piece. So spending a lot in Kosciuszko County, you probably couldn't spend as much in Floyd or vice versa. You have to be aware when you're planning that it has to be the whole. And that's not just true of IT.
No, same with administrative costs and things like that. So that is part of how we built the budgets. The budgets that were required were pretty detailed as far as planning this out so that, you maintain those thresholds. So this one, again, increased awareness of the current technology and infrastructure that are currently used by rural health providers. Rural provider adoption of new interoperability and HIE infrastructure enhancements. Again, the basic things that we have talked about in the past, county level access. So I'll switch it over now to John to talk about Initiative 4.
Yeah, so that one is the pediatric and obstetric readiness in rural emergency departments. Even though the title says rural emergency departments, this also includes the EMS. So what this is going to make sure that those emergency departments, as well as the EMS that are transferring them, are all equipped with the tools needed or the experience needed in order to take care of infants and small children. We know that across the state, it's not always that case. So this will work with looking at the overall delivery and hopefully increase the stabilization and successful transfers of those little ones. We are going to partner with the Indiana Emergency Medical Services for Children, or the IMSC, and then as well as the Department of Homeland Security to look at the needs assessment, training, equipment, and technical assistance.
Initiative 5.
All right. This is the improving the cardiometabolic health standards of care. So this will create a statewide collaborative care model to combat obesity, diabetes, and cardiovascular disease. We are going to create a cardiometabolic center of excellence in each of the rural health regions. Our goal is to equip 6,000 rural health professionals with lifestyle medicine. as well as train up 2,000 clinicians to lead preventative care. The idea with this one is, again, focusing on that prevention efforts and helping to reduce hospitalizations and readmissions, and also importantly, identifying those increased risks with cardiometabolic risk factors.
John, on the previous one, we were asked, what about hospitals that already provide OB services?
So this one will be specifically for their emergency departments. So there are ones that have OB services, but that doesn't necessarily guarantee that your emergency room will be, the practitioners there will be trained up, or that they will have the equipment that they're needed. So that's part of the importance of getting that survey and needs assessment done, is then we can see where those gaps occur. All right, initiative 6. This is the Meds to Beds program, or for purposes of being formal, the hospital post-discharge medications program.
This actually makes sense, meds to beds.
No, but it rhymes. And it makes sense. So this is ensuring that all the patients upon their discharge
I
are
don't think the feds care about meds.
being prescribed the medications they need before leaving the hospital. This one, again, is probably going to be one of those upfront questions we have. Like, this is a lot of it, things we can do early, and we'll be looking to see the number of hospitals participating with the goals that this will reduce readmission rates as well as decrease ED utilizations. We heard from a lot of folks that in the rural communities that oftentimes getting access to the medications that you were prescribed at the time of discharge can sometimes be difficult due to transportation or sometimes pharmacy hours.
So I don't think this is, we talked about, did we do 340B pricing budget discussion? Not this budget, this state budget. Okay. So there's this 340B state plan amendment coming. That's just a heads up for you as you are working on this, that it may throw a wrench in this one.
Okay. Keep in mind that.
We were also asked, will this initiative include helping develop or expand retail pharmacy programs within our rural hospitals?
I think on that one, it depends on what we're talking about, the expansion and the development of those retail pharmacies. But I'm definitely wanting to make sure that we can identify any of those barriers of like systems either, or what they could use as far as common solutions. I'll sit this question about the discharge from EDs or just discharge from a patient. We want to make sure that everybody leaving the hospital is going to have access to the medications that they need. All right, initiative 7. This one is the teleconsult. So specifically this specialty provider access through expanded teleconsult capabilities. We know in rural communities that oftentimes getting a specialty care or being able to have that quick access sometimes cannot occur in some of our rural hospitals or rural areas. So what this will allow is clinician to clinician connection and allow the teleconsultation system to be able to better leverage that. And we hope to eliminate some of the barriers like the credentialing and payment incentives in order to help improve that rural health infrastructure. One of the things that we're looking at is the increased ability to treat and discharge inpatient patients and avoiding transfers due to tele-specialty consultation. All right, initiative 8. This is the improvement to the telehealth access and infrastructure. This one I think everybody probably has a pretty good understanding too, but this will look at and conduct a statewide feasibility study to assess the rural provider networks, our infrastructure gaps, and then the opportunities for remote health monitoring using wearable devices to reduce clinician burnout and improve patient outcomes. So really just kind of rolling out the unified telehealth system and being able to look and see how we can improve rural connectivity. All right, initiative 9. There's only 12 of these, so. All right, this is the growing our rural health paraprofessional workforce. This is going to be the expansion of our community health workers. Specifically looking at funding, certification, and upskilling those community health workers, as well as creating a career pathway for programming for rural high school students so they can have that early exposure to the training and what a career in health could be. Our goal is to increase the number of credentialed healthcare workers in rural counties, as well as increase the number of those certified CHWs. All right, initiative 10. This is the expansion of the GME capacity incentive for physicians to practice in rural communities. So this will, we know that from the application and from the FAQs that we had, that we could not do, there could not be anything like loan forgiveness, but what we could do is do targeted grants and stipends in key specialties, such as primary care, pediatrics, OBGYN, and general surgery. So what the goal of this one is to increase the total number of residency programs operating within the state, as well as creating the increasing the number of service commitments in rural and underserved areas. We are also aware just from our own studies that oftentimes people continue to work on where they train. And so the goal for this one is to try to get people trained in those areas, get that exposure, sort of clarify what it is to work in rural communities. And then with that, then incentivize people then to stay there.
We should call this the Doc Hollywood Initiative.
If we can't have meds, can I have meds?
You know Doc Hollywood?
I do know. That's, the next one is the growing our rural behavioral health workforce. So again, kind of probably well understood the needs of rural behavioral health workforce in our rural areas. So this is creating university-based certificates and degree programs, offering scholarships and stipends, and introducing career pathways for high school students. We're hoping this could increase the local hire rate in those rural communities, as well as just expand that workforce.
And Sarah, you're
I saw that.
doing this one.
And then lastly, initiative 12, probably the one that we will get probably the most questions about, which is those regional grants. So with this, we have a budget of $600.2 million over the 5-year period. So that represents a little bit more than 60% of the total funding from the Rural Health Transformation Program. The state's going to implement a rigorous multi-layered oversight and balancing accountability with flexibility. So I think in the next slide, we kind of break down what that oversight looks like. So we'll have the Executive Oversight Committee, and this will be leadership from the Health and Family Services vertical and the Governor's Office. This will help steer a lot of the decisions for applications, including that final determination on funding amounts and oversight and reporting. Underneath that will also be the Regional Grant Steering Committee. This committee will include community and legislative leadership, as well as the State Executive Oversight Committee. And they will meet quarterly to review the region's activities, data, and outcomes, and will help provide that guidance and direction that the regional areas would need to make a success of the program. So lastly, the Regional Committee. This is going to, each regional committee will include 11 members approved by the State Executive Oversight Committee, representing key health stakeholders. At the very bottom is a box that includes what each committee must include, including members of the General Assembly, non-provider medical workforce representatives, pharmacy representatives, as well as just community-based organizations. And they must meet quarterly to provide oversight and encourage collaboration. And then lastly,
Can you go back to us?
Yeah.
I'm gonna just tear since I can't read that.
I haven't printed out.
It's okay. Okay, thank you.
All right.
This is very good. Can I quickly ask a question? So who will actually determine who makes up the committees?
I believe it is approved by the State Executive Oversight Committee. So that one is the leadership from the Health and Family Services vertical in the Governor's Office.
Okay, thank you.
All right. And on the next slide, we actually detail out what must be submitted with each of these applications. And I hate to leave from reading the slide, but they all are important. But the comprehensive need assessment, The use of local health data and community needs assessment, plans to eliminate duplication, share costs, and fill service gaps. The service delivery innovations and measurable KPOs, letter of support from stakeholders, and probably most importantly is that sustainability plan and compliance acknowledgement. We know one of the big risks with this is that the federal government has the ability to claw back any of the money that's given out. And so we want to make sure that we are at every time having that oversight, but more importantly, that the plans are sustainable, that we don't leave anybody with cliffs, or that we don't run anything where there's an issue where somebody's not complying with the requirements of the grant. The grants will be distributed amongst the 8 regional coalitions, and those awards will range between $4 million and to $100 million over that 5 years. Okay, Sarah, I think you are next.
Quickly, how can we ensure rural hospitals are represented
So
on
who are you?
regional committees? Julianne, but this is a question from Kara in the comments. As part of the grant structure.
I think it's just really, I mean, we can flag that. We will be the ones that will be overseeing that and actually in selecting that. So we will make sure that we have the proper representation of all of those.
Thank you.
Same question with community mental health centers too.
And I think that that's kind of the goal, the way that it was originally set up was to provide that flexibility, knowing that each of these regions are going to be slightly different. Each are going to have varying stakeholders and different levels of engagement. So this kind of allows that really strategic opportunity.
Okay, so as far as the regional grants application timeline, so this is really important. We talked to CMS about this multiple times, about this regional grant concept. And as you can see from the oversight that is in place, it was very important that the state maintains that executive level oversight, but also the functional oversight of these grants. So the goal is to create an application that would be released in March of 2026. And it's going to be a very comprehensive application that, you know, similar to really what we had to submit to CMS for the grant money for the state. It'll look very similar with similar requirements. But again, it needs to be catered to that particular region of what makes the most sense. So not everybody will be asking for the same types of dollars. There's the menu of opportunities for, you know, what this particular region needs most. And then the grant should be structured that way, but the application will be consistent as far as what is being requested of each region. And then from March to July, we'll have technical assistance available during that coalition formation and application development. And then July 1st, applications will be due to the state with a review from July through September. Depending on time in September, there's other initiatives. Some of those statewide initiatives will be things that we need to continue pushing forward. Some of the quick hits where we can, build the infrastructure needed for some of those statewide initiatives, because we do need to show progress in our in how we're spending the money and that we are moving in the direction that's expected. Again, there will be monthly, if not more, probably more communication with CMS. We'll have a dedicated person assigned to us to walk us through some of these questions that might come up along the way, and to make sure that we are gathering information so that when we do have an evaluation in September of 2026, that we're producing what's expected and that we can show progress. So that is going on simultaneously with this other process. And then October 1st, the grant agreement period would begin, and then funding distributed to individual entities at that point. So that's the schedule of what this would look like from a regional grant. We know it takes time to develop these coalitions, and not only the coalition, but then also what it is that's the priority in that particular community or communities. And then I think the outcomes are really important to look at with these regional grants. It's a lot of outcomes that are expected, but it's also 60% plus of the overall funding. So the identification of the duplication of services and gaps is really important. So we don't want to create the same thing 12 times. If it's something that we can do a couple of times, but then we create something new in some areas where there's a gap. Increased care of, some of those most vulnerable populations that we know exist that are, called out in the NOVO, pregnant women in particular. Increased access to preventive services, connection to appropriate primary or specialty care, improved cardiometabolic programs, increased workforce recruitment, and then leveraging the collective healthcare providers in rural Indiana. So those are really the outcomes that we're looking at. Again, rural hospitals are absolutely part of this conversation. So we want to make sure that that is not over glanced over. Again, it's going to be important that each of these communities know what is needed within their community. And that will be part of the application within those regional communities. And then as far as our overall key performance objectives, John, do you want to jump with this?
Yeah, so it's to improve chronic disease indicators, decrease ED and hospital utilization, improve maternal and infant health outcomes, improve the rural health workforce stability, improve timelines and access to care, data interoperability, telehealth and teleconsult expansion, and cross-sector collaboration. And all of those KPIs match what CMS was requesting when they released their notice of funding.
And you can see those aligned with, obviously the initiatives that we have. So again, CMS had quite a few meetings with different leaders within the state, and they made it very clear. I mean, this was kind of the questions were leading to more questions. So we actually received a final updated FAQ the Friday before the application was due, and it added another 20 some pages of questions and answers. So, we did the best we could, as did every state, to keep those aligned with how we were answering or how we were addressing things. And it did lead to some, changes in some of our terminology and how we were addressing things at the 11th hour. So there was a lot of time and thought and effort put into it. So I did want to call out that, we added this to our website, but, I know we have a lot of vendors, consultants, associations who submitted ideas and initiatives. Just because you don't see specifically what you said called out doesn't mean that there isn't a purpose or an opportunity. I think what we have to do is put the initiatives forth, and then as we're working on each of these initiatives, there will be opportunities to bid on some of these. And so I think that's really important because we're getting a lot of outreach from different vendors and asking, was our proposal included? We used those proposals, as we said before, at the very beginning, we were using those proposals for ideas of how we could accomplish some of these things, what was important. Some of those were actual input into some of the initiatives. So just because we submitted the application does not mean the work is done. So we want to make that clear. However, because of the breadth of what this covers, we can't respond to every single vendor that responds or reaches out. So we do ask that vendors continue checking the website, as well as we will stand up. We're going to talk about that here in just a minute. But we do appreciate the outreach. However, at this point, we are now in the planning stages of what those RFPs and opportunities look like. So we do appreciate the outreach, but if you could just keep checking the website for any of you or vendors. Go ahead.
So maybe this is self-evident, but I'll say it anyway. So bend your ideas to fit inside of one of our buckets.
Thank you. Next steps, pre-planning. That's already happening. So we have initiative driven stakeholder meetings to determine RFP identification and preparation, as I mentioned, shovel-ready grants ready for funding, identification of state and contract staff and the job descriptions associated with those, and then identification of stakeholders beyond IDOH, FSSA, and the working group. So those are things that are happening right now as we plan for. I mean, we've already hit the ground running. And so it's not like waiting till January 1st, but we can't really formally engage any vendors or any engagement until we have been approved. So But there's a lot of planning, or the creation of the work plan, including a robust communication plan, is in the works, as well as a funding distribution process for each initiative. And again, questions about how the money is going to be distributed, that will be included for the regional grants, that will be included in the regional grant application process. John, you have anything to add to the pre-planning steps?
No, thank you.
And then as far as communication, we will be creating a Grow Cultivating User Health website. We have the working group website, but we'll have one that, where we will include the regional grant application, results of the stakeholder survey, so that, individuals can see, here's who we reached out to, here's the information that we received back, an informational slide deck about the application that we submitted, for those who are interested, as well as a quick fact sheet, which again, could help you prepare if you are a vendor and if you have a solution that could fit into one of our initiatives. This would be a great time to really dig into those initiatives and figure out where you might fit. And then other communication preparation is some regional tour dates and a press release ready for when we have the final notice. John, do you have anything else to add to that?
Are you doing, I'm sorry, go ahead.
Yeah.
Please. Are we planning on doing a roadshow?
Yes.
Yes.
Yeah, I think the plan is to at least get out and to some of the regions once we're able to identify them so that we can hear.
All right, so just from a cost and time management, I would like to have them in those, the roadshow include HIP 3.0 conversation.
Okay.
So she's also heading up the HIP 3.0 efforts. Dr. Weaver is well aware of that. We've got a planning deck. We waited until we got to this stage to start HIP 3.0. But so I would, I'd do like 2 hours on this and an hour on HIP 3.0. They're related, but likely to have similar interest groups.
And so here we have, I know this is very small, but this presentation will be posted to our website. But this is the breakout of each of the initiatives, the total amount that's included, and then the costs or the percentage of the total. So if you have any, it should match up to what we shared. And the total was $1 billion. Not a penny over, not a penny less. That's how CMS instructed us to budget for $200 million per year for 5 years. So
There you go.
it's surprising in an Excel spreadsheet how difficult it is to actually come up to exactly $1 billion.
Every
7
cent matters.
Did it?
Did.
All right, well, thank you very much. We'll be happy to try to answer questions and listen to your comments. And we have one in the room from,
Ann Hazlett with Purdue. Tara, I apologize. The spreadsheet, remind us, is there another bucket of money that we may be able to compete for? Or is that all of the dollars?
No, that is all that we were told to apply for.
Okay.
However, if we go back to the very beginning, it's a little bit confusing with this money because half of the money, if all 50 states apply and get approved, half of the $1 billion, 500 million, gets split between the 50 states. Then the other half of the money is split according to the quality of your application, which means the points that you received as your application is assessed, as well as there's some discretion involved there, the rurality of your state. And the discretion is on the CMS administrator. I mean, it specifically calls that out. So I think we did have some areas where we were proactive in some of our state policies that were already implemented. And, for example, the SNAP, that's an easy one, removing some SNAP or some products from, being eligible for sugar products. So that we got 100 points for that just because we already had that policy in place.
Okay.
So we were able to also align our Make Indiana Healthy Again initiative Governor Braun, and, RFK Jr. and Dr. Oz were here for that. So, we called that out in our application. So we were proactive in some areas that helped us with some points. But again, is it a comparison of all the other states? We don't really know exactly what that formula looks like other than what I just shared. If that makes sense.
Yeah.
So it could be more than $1 billion. It could be less. It's all dependent on other states and.
Which is why we are trying to use this time for like the pre-planning to get as many things that we possibly can, so that when we do get that number on December 31st, that we are ready to plug that in and then have everything kind of move, hoping that it is higher.
Yes, sir.
Dan Hardesty with the Rural Health Association. If the number is higher, where does that money go? Where's the extra money go?
No,
Medicaid admin.
probably not to, probably the easiest answer to that would be, it really would depend on like how much more money we could get. I mean, some of these things like the telehealth or the infrastructure, the interoperability, those things can be funded pretty high. And so it's just kind of looking overall is like which one we're gonna have the most at. So I don't really know.
We also know during the application review period that they will be going to different states. They feel it's appropriate and have a discussion like, okay, we like 12 of your or 11 of your initiatives, but we really don't understand how this one is a good idea, or and allow for an opportunity to make some revisions.
Hey, just a minute. Zoe has a question. Zoe has a question and is too shy to take herself off of mute. How will the 211 initiative
Mitch,
interface?
I'm not shy. I'm not shy. I've never been called shy, but I just didn't want to interrupt the conversation. So yeah, I had two questions. The 211, how will that initiative interface with 988 and crisis services? And then my other question is, I love the GME and physician program, but did not note psychiatrist as part of that. So was that just an omission off the slide, or will psychiatry be able to qualify for that in our rural areas?
I can't imagine why it could not be. I think we just had highlighted a few that we knew for areas for improvement in rural areas.
So that's the answer to your second question. The answer to your first question is, I think, oh, good to see you now. The answer to your first question is, I'm going to turn that over to Tara to talk about how we're going to interface 211 with crisis.
Yeah, so that's an ongoing conversation that we have internally with DMHA as far as that interaction goes. At this point, the funding sources have been different. So, we're working on that all the time. And so I think this opportunity to establish some infrastructure that we could then, tag into that would be really helpful.
Wonderful. Thank you.
Sarah, do you have any thoughts on that?
No additional thoughts here. Yeah, thank you. Tara Beal, you want to go ahead?
Sorry, I couldn't be there in person today. I have a couple of immediate questions. Can you elaborate on the unified telehealth system and what that means?
Yeah, so from the application that we put together, we just said that we would do some study to find out where those gaps are, and then look at doing an RFP to see if there's an opportunity for a unified system that could come in order to help alleviate some of those issues.
When you say unified system, does that mean like it's the preferred telehealth vendor, and if we already have a telehealth vendor, we transition to that one, or that's optional at that point? It's just an additional resource? And then if that's the case, do we feel like it's necessary to implement dollars to create an RFP for that?
I believe in the application that we had it so that it was supposed to connect different telehealth systems as well. So if there's one that you have and you're utilizing, not necessarily to replace that, but instead for those areas that we have those gaps.
Okay, another question. We talked about paraprofessionals in one of the initiatives, and CHW was only listed. Is there room for additional training and development for other paraprofessional positions, specifically thinking like perinatal navigators, insurance navigators, oncology navigators?
Yes, we are still looking at that as well.
Okay, so
that
it's
was-
not specific CHW.
No,
Got it. Sorry, I'll just keep going down my list and then I'll turn my camera off and turn my hand down. For the initiative, for each of these initiatives, are there already sustainability plans in place, or is that part of the process moving forward as we start to implement these?
all of the 11 initiatives all have sustainability plans built into them. The 12th one for the regional grants, that is where we're going to be leaning on those regions then to demonstrate how their grants will be sustainable.
And the sustainability fund plan is not Medicaid will pay for it.
With that sustainability piece, do we know or have an idea on some of these initiatives, some or all of minus the regional grants piece, what the ongoing costs look like post period of performance?
No, we have not had our actuaries look at this, so no, we're not there yet.
Okay, got it. And then I think one of my last immediate questions to the regional committees. So the regions don't self-select the representatives. The executive oversight at the state actually chooses the people.
You can nominate. We'd be appreciative of nominations either by others or you can self-nominate. So we'd like to know, right? We don't know everybody in every
Right.
rural portion of the state, right? If you asked me to go find somebody who could do this in Lagodi, Indiana, I'd be hard pressed.
Right.
So yes, we would be appreciative of particularly your continued nomination of people, and people on this committee can nominate. People can from any place in Indiana can nominate themselves or others. But we're gonna have to have a nominating form, so we get your background and, Yes, sir.
Maybe to add on, Andy Van Zee from the Indiana Hospital Association, to add on to the, I guess, concerns with the regional committees. Some of these regions are going to be 10 to 12 counties. So one, selecting individuals that can represent, I think, the whole region could be challenging, as well as, I guess, a general concern that if the health of rural hospitals is a big component of the outcomes, there's no mention of rural hospitals on those regional committees.
Okay, good catch. You earned your money today. Kara, were you done?
Yep, I'll give somebody else a turn. Thank you.
John Kansky.
John Kansky, Indiana Health Information Exchange. On initiative 3 that included the HIE modernization, is there anything known at this stage about how front-loaded or back-loaded that is, or whether the work and funding is expected to kind of be spread across the 5 years?
I would expect it to be front-loaded. I mean, in part because we've got to spend, just frankly, we don't start spending. I mean, if you look at the budget, right, you've got 60% of the money that we're going to spend in 4 years. And so 40% of them, so we're just going to have to spend more money in the first year.
Gotcha, because the 600 million doesn't even really start to get spent.
Right. So we're going to have to, so that's why we've picked infrastructure projects that can be where we can spend the money up front quickly, like yours, and we're assuming that it's.
Keep in mind that first year, yes, we have to spend money, but we have until just September of 27 for that first chunk, but we have to show progress in September of 26. We're going to have 10 months or 9 months to show progress.
Very interested in learning about chunks.
10 more. Okay, other questions for the good of the cause?
Scott Smith here online from Adams Memorial Hospital. Back to the cardiopulmonary centers of excellence. Do you have an idea? Do you plan that those will be hospital-based or clinic-based or to be determined? That's kind of a relatively new twist to the application as far as those of us who have been involved in some of the meetings. So I'm curious what you anticipate there.
Probably yet to be determined. It's like, I think I will look into it.
Thanks for the question.
Yep, thank you.
Other questions for the good of the cause?
It's Zoe
Zoe.
again. I had a couple more. So kind of along the same thing that Andy and Kara were saying around the regional, with mental health being listed as a key component of the rural health funds, listing mental health in the local community mental health centers, I think would be crucial in that discussion in the regional areas. So similar along those lines. And then my other question is around KPIs. So how will, like, things that we're doing in system transformation around crisis that we are seeing ED utilization go down, how will some of that kind of speak to some of the rural health KPIs? And has the state kind of looked at some of the other transformational things we're doing across their state to kind of help with some of the other KPI indicators?
I think one of the things that we were trying to do when setting up the KPIs was try to make sure that it's things that we are already and have the ability to collect, so that we're not having to build new systems or structures to capture that information, that we're already having those ready-made for things that we're already tracking. So we definitely don't want to create a scenario where now you're tracking all A through B, and then now we have a C through F that now we want you to do. So we're trying to make sure that they align as well as possible.